So for this audience, I'm not going to talk about too much background of AKT signaling, as so many previous speakers have showed a lot of signaling pathways. But clearly, AKT is downstream of B-cell receptor signal transduction pathways. And work from our group as well as from other groups have shown AKT is downstream a lot of environmental signal, specifically the interaction between leukemic cell with the bone marrow microenvironment, as well as in the lymph node environment, AKT is an important signal. So that makes it a natural target to be used in the relapsed CLL disease. The compound we used in this study is MK-2206, which is a small molecule inhibitor developed by Merck. This is an allosteric AKT inhibitor, have relative specific targeting effect, specifically the IC50 for AKT1 and 2, which are predominant form in lymphocyte, have a low IC50 nanomolar dose, is in the 8 or 12 nanomolar. For AKT3, which is not a lymphocyte predominant isoform, the IC50 was much higher. And this inhibitor has been used in a single agent in relapsed solid tumor, has been shown to be safely administered. So we started this study a couple years ago to test preclinical activity of this agent in CLL disease. We tested about 30 patients using CLL leukemic B cells compared to the normal B cells. It's very similar to other signaling inhibitors. This agent alone does not kill the CLL leukemic cell very well. The IC50 is about 8 micromolar. However, it still kills better for CLL leukemic cell compared to the normal B cells. In the figure B here, you can see this agent also showing the targeting effect by blocking the AKT phosphorylation, specifically in the serine 473 site, as well as the downstream target of P70X6K kinase. And it also caused the PARP cleavage with increasing dose of this agent. Next, we want to ask a question, can we combine this agent with some of the established chemotherapy agents? At the time, we decided to combine this with bendamustine. Among about 12 patients that we tested, most patients have shown there's a synergistic effect of this agent in combination of bendamustine to induce CLL apoptosis. And shown here with the figure 3, this is a graph showing the combination index of those two agents used to kill CLL cells. So any CI index less than 1.2 shows potential synergistic or addictive effect. Given those data, that we subsequently developed this combination of the early phase clinical trial using AKT inhibitor MK-2206 in combination with BR in relapsed CLL patients. I'm presenting this data as more updated data from ASH 2013 presentation on behalf of my co-investigators. In regarding the schema of these trials, we developed this combination of treatment for total 6 cycles. Specifically, this is different from other novel agent in combination of BR. We do not have extension phase after 6 cycles of the treatment. For the cycle 1, we have 1 week run-in of MK-2206. I should mention MK-2206 have a relatively long half-life, about 3 or 4 days. That's why the dosing of this agent is once per week. So this is also different from other signal inhibitors. And starting the second week of the cycle 1, we use the standard dose of the BR as developed by German CLL group. From cycle 2 to cycle 6, we started the 3 agents together. Specifically, the rituximab used was 500 milligram per square meter. 2 months after 6 cycles of therapy, we evaluated all patients with bone marrow evaluation as well as the CT scan. We categorized the patient's response based on IWCLL 2008 criteria. We also, in the patient who achieved the CR, we also measured the bone marrow MRD. And the 3 doses that we used, tested in the early phase of the study of MK-2206 was either 90 milligram oral once weekly, or dose level 2 is 135 milligram oral once weekly. The dose level 3 is 200 milligram oral once weekly. This dose level 3 is determined MTD based on the refractory solid tumor trial. The primary goal of the study for the phase 1 is to determine the safety as well as determine the maximal tolerated dose of MK-2206 in the combination. The phase 2 of the study is to assess the efficacy of the combination. For the patients enrolled in the study, initially we're trying to focus on the patients who has a similar profile as a German CLL group used in the relapse setting using BR. So we selected previously treated symptomatic CLL patients who had up to total 3 prior lines of therapies, have reasonable ECOG performance status and adequate organ function. Given we don't feel the BR is adequate treatment for the 17p deleted patients, we actually excluded the 17p13 deleted patients. We also excluded prior use of bendamustine or AKT inhibitor. This slide showed the patient characteristics so far has enrolled into this trial. There's 13 patients enrolled into this trial. The average age of the patient enrolled is about 68-year-old. Majority patients are male, 2 patients are female. And regarding the CLL facial abnormalities, 31 patients, which translated into, 31% of patients or 4 patients had 11q deletion, and 2 patients had trisomy 12, 3 patients had 13q, and 4 other patients have either normal or other cytogenetic abnormalities. Majority of the patients that have IGHV mutated status, actually among all 11 patients, I would say the one who has mutated status only have 2.1% of a mutation rate. A majority patients have ZAP70 positive disease or CD38 positive disease. 90% of patients have received a complete chemoimmunotherapy in the past in the format of either FCR or PCR or PCO or PCR lenalidomide. The median prior line of therapy in this study included is only 1, but however, we counted if a patient have received, for example, 2 different time point of FCR or 2 different time point of PCR counted as 1 line of therapy. First, I want to show some correlative study that we performed in this trial. Similar to other signaling inhibitors, with MK2206, because we really only have 1 week timeline to do those correlative study, we measured the absolute lymphocyte count pre-therapy at day 0, as well as day 8 after 1 dose of MK2206. On those measurable patients, majority of them have also increased the absolute lymphocyte count. So this is consistent with other signaling inhibitor was able to mobilize lymphocyte. I should mention here, once we add BR, basically those lymphocytosis is gone, is ablated. We also measured the BCR receptor-related cytokines. We have performed a preclinical study to test what are the major cytokine-related BCR stimulation detected in the CLL cells. Similar to what has published by Young-Berger as well as others, the CCL3, CCL4 were showing to be significantly elevated. We also detected a couple of other cytokines. So we measured in those trial patients 1 week after the single dose of MK2206 if those plasma cytokine has been reduced. And the majority of patients measured here, actually the cytokine have reduced to different degree of the CCL3, CCL4, and CCL2. I should mention here those 2 patients who has the red text actually have increase of those cytokine level. And those 2 patients turn out to be 2 out of the 3 have the least increase of ALC increase. We thought that was interesting to point out. In this trial, we did experience about 1 dose-limiting toxicity in dose level 1, and that patient developed febrile neutropenia as well as hemolysis. So the dose level 1, I want to remind everybody, was 90 milligram oral once weekly with BR. For dose level 2, which is 135 milligram oral once weekly with BR, there are 2 patients developed dose-limiting toxicity. 1 patient had febrile neutropenia and diarrhea. Grade 3 diarrhea really required some hydration and stopping the therapy, but that patient improved afterwards. The second patient had a grade 3 rash. So based on this data, we decided to use dose level 1 as maximum tolerated dose to going forward for the phase 2 study. In regarding the adverse events that we observed in this combination of therapy, I presented the grade 3 and 4 adverse events here. The most significant hematologic toxicity that we observed was neutropenia. About 50% of patients had grade 3 or 4 of neutropenia. Half of them had febrile neutropenia. But I should point out there's really only 1 patient had demonstrated bacterial sinusitis required hospitalization. Regarding the non-hematological toxicity, goes along with other signaling inhibitors. The most frequent one that we observed were rash as well as diarrhea. I should mention there's one patient did experiencing tumor lysis, but it's not a very hyperacute tumor lysis, so more like biological tumor lysis associated with renal failure. The patient was conservatively managed, was able to recover. Regarding the clinical efficacy with the small cohort of patients that we treated, we have treated 12 patients, enrolled 13 patients, treated 12 patients. There's one patient still ongoing with the therapy, so we don't have a response evaluation. With those total of 12 evaluable patients, actually the efficacy-wise overall response rate is pretty high that we observed. 11 patients have experienced different degrees of clinical response. 4 patients had achieved a complete remission. 1 patient achieved a complete remission with insufficient marrow recovery. Actually, that patient have a mild thrombocytopenia. 2 months after finishing the therapy, the platelet count is around like 80,000 range. 1 patient experienced nodular partial remission. 5 patients had partial response. And among the patients who achieved a complete remission, and 1 have MRD negative disease, 2 other patients have less than 1% MRD. The number 4 patient had more than 1% MRD in the marrow. In regarding which dose level achieved a better clinical response is clearly not the more dose is better. In the dose level 1, we have seen 4 CR and 1 CRI. And in the dose level 2, we only observed 3 PR. So I know we are not supposed to compare, but it's a human nature that we always compare. So I'm trying to compare our very small cohort with the initial German published experience with BR in relapsed CLL. So in the German experience that published in JCO of that paper, there are 78 patients treated with BR. And the median prior line of therapy was 2. In our trial, and we have median prior line of therapy of 1. We did exclude the 17p deleted patient. They included about 18% of patients who had 17p deletion. However, I think we observed a pretty impressive overall clinical response with impressive CR rate, given that's a small cohort. And we also seen more frequent grade 3 and 4 neutropenia occurred in about 50% of patients. In the initial German experience, about half of the patients experiencing grade 3 and 4 neutropenia. And I also trying to compare with other novel agent combination, specifically ibrutinib with BR, as well as adalimumab with BR. And the difference is our trial, we don't have extension of the single agent. The other 2 trials have extension of the single agent after 6 cycles combination of therapy. So you can see across the board, the response rate is all quite impressive. Overall response rate is all close to 90% or over 90%. The CR rate is higher with our group, but we have a small trial. Adalimumab seems to have a little lower CR rate compared to the other group. Ibrutinib with BR have about 17%, but I think the other 2 trials also included 17p deleted patients. Regarding the side effect profile, seems the neutropenia is predominant in all 3 groups, and diarrhea also is predominant side effect observed. So in summary, we believe the AKT inhibitor MK-2206 appears to be tolerable in the combination with BR in relapsed patients. We also observed mobilization of the lymphocyte. The preliminary efficacy of the combination appears to be promising compared to initial German experience, although we have very small cohort. And further testing of the efficacy of the AKT inhibition seems is an interesting target to us. Unfortunately, I should mention here, this is more compound. They decided to stop development of this agent, so we won't be able to totally complete the phase 2 portion of the study. And we're trying to look for alternative source of the AKT inhibitor to have further ongoing study in this cohort of patients. At the end, I'd like to acknowledge my collaborators and coworkers in the Mayo CLL group, as well as in the NCCTG and Alliance group, and also like to acknowledge my funding source from NCI. Thank you.